Most of us have been taught to think of arthritis as age-related and mechanical wear and tear and breakdown in the joint. We stood on concrete floors all day at work, or we typed on a computer all day. We ran too much, we jogged too much. We played sports our whole lives. This led to mechanical strain on the joint and the cartilage and the soft tissue in the joint. Well, in many cases that's true, but not in all cases. Why do we see some healthy, fit, active people in their 30s and 40s with advanced osteoarthritis, degenerative discs, and joint breakdown, and osteoarthritic symptoms? And then we can see elderly people, overweight, doing the exact same activities and same job, standing on the same concrete floor, and they're extremely mobile with no joint pain. Why does someone standing on a concrete factory floor develop hip and knee pain when their coworker standing right beside them works there for years and develops none of that pain? Why does someone sitting at a desk typing for their job all day have chronic wrist pain when their coworker sitting next to them does the exact same job and their wrists are fine? If repetitive mechanical wear and tear in the joint was the main cause of the arthritis, then both of those workers should have the exact same symptom picture, and they don't. There has to be another factor determining why some people's joints break down faster than others. For many people, that differentiating factor is chronic inflammation in the joint. Inflammation could change the chemistry and the pH of the fluid inside the joint, and it's this chemistry change that can lead to the more rapid breakdown of the cartilage and soft tissue in the joint. This is why I think the more important question to ask isn't what mechanical function broke down the joint too quickly, but what physiological issue is actually leading to the breakdown issues in the joint. What is inflaming the joint? The common thinking is that the joint breaks down and this leads to inflammation surrounding the joint. But for many of us, that order is reversed. Chronic inflammation can lead to the rapid breakdown of the tissues in the joint. This can explain the variations in those examples I mentioned earlier. There's a simple clue that most of you have already tried to determine this inflammation issue. Quite often with osteoarthritis, we're prescribed NSAID medications, non-steroidal anti-inflammatory medications, naproxen, ibuprofen. And for many people, these medications work extremely well. The pain and the inflammation eases. But osteoarthritis is non-inflammatory joint pain. It's bone banging on bone. By definition, there's no direct inflammatory process involved in osteoarthritis. So if those medications help, it has to help with an inflammatory process. In this video, we're going to explain how the joints aren't just mechanically breaking down. There's likely inflammation around the joint first, and it's this inflammation that's leading to the premature rapid breakdown of the soft tissues in the joint. The breakdown can actually be a secondary process to the inflammation. So let's talk about inflammation and arthritis. Now, if we break down the word arthritis, it simply means we have inflammation in the joint. But there are actually two different diseases that use arthritis terminology. We have structural arthritis. This would be cartilage wear and tear, breakdown as we get older, mechanical strain, injuries, and trauma to the joint. That can tend to damage this cartilage in between the joint, which acts as a cushion between the two joints. We don't get bone banging on bone. We have a bit of a pillow in between the two joints. So the pain with osteoarthritis is actually bone on bone pain. It's not direct inflammatory pain. Then we have inflammatory arthritis, which is immune-mediated inflammation. The immune system creates an inflammation response around the joint, and that could lead to changes in the joint. So we have two different types of arthritis, but we tend to use arthritis as a catch-all term for joint pain. And this has to be differentiated in order for us to truly understand where joint pain is coming from. So with structural arthritis, it's structural breakdown. Quite often we can get osteophytes or little bone spurs in the joint. The cartilage tends to thin and get brittle, so the bone starts to get closer to the bone. We can get cartilage loss, as we mentioned. Why the terminology is important is because this type of arthritis, it affects the management of that pain condition. Because it's a structural change in the joint, management and pain control are going to be directed by that. So physiotherapy, hot and cold treatments, various forms of pain management, and ultimately, if the joint breakdown gets bad enough, we end up with joint replacements. That is the standard of care for structural arthritis. The key point I want to make here is with this type of arthritis, the structural breakdown is the primary action leading to the problem. Structural breakdown in the joint can start to irritate the soft tissues around the joint. So the soft tissue inflammation tends to be secondary in this form of structural arthritis. Now with inflammatory arthritis, this is when the immune system, something triggers the immune system to attack the soft tissues around the joint. It's this inflammatory process around the joint and the physiological processes associated with it that can lead to premature rapid breakdown of the soft tissues inside the joint. The key point here, inflammation around the joint is the primary problem. This leads to secondary damage in the joint. So the causation is actually reversed. More common thinking says structural damage to the joint will lead to inflammation. This concept we're talking about here, inflammation in the joint, can lead to structural breakdown. It's this paradox in thinking that can explain those differences in the people that we talked about in the intro slide. So the differences in terminology, they're not just technicalities or semantics. It can actually have big impacts in terms of how you manage the condition and the outcomes associated with the condition. That's really important to keep in mind. So the wear and tear paradox, we can have a young, healthy, fit person on a new factory floor job, and she's suffering with wrist pain, elbow pain, hip pain, knee pain. And she's working next to an employee who's been in that job for 25 years, doing the exact same work. She's overweight. She's not healthy and fit like the younger person is. And she's very mobile. She has no joint issues at all. So if wear and tear and weight and those sorts of things were the primary issue associated with the osteoarthritis in this case, the situation with these two women should be reversed, and it's not. The imaging paradox. With x-rays and diagnostic imaging, sometimes we will see modest forms of osteoarthritic changes, sclerosing in the joint, joint space narrowing, things like that. But the patient isn't suffering. They're healthy, they're fit, they're active, they're walking, they're golfing, they're running, and they're jogging. So their joint health shown in the x-rays doesn't really fit with what their activity level is. So then we can see that a similar person, same age, same fitness level, have mild to almost no issues on x-rays and diagnostic imaging, and they're crippled over in pain with knee pain and hip pain and joint pains in general. So the paradox here is the imaging doesn't always correlate to the pain pattern we see in the joints. We can have healthy images with people with joint pain, and we can have images showing joint breakdown and joint deterioration, and those people sometimes don't have pain. So if diagnostic imaging told the whole story with respect to how your joint space looks on an x-ray and the degree of pain you have, this wouldn't be the case, and we see this quite often. A simple thought experiment we can do here. In the intro, we discussed osteoarthritis as non-inflammatory joint pain. The bone is banging on the bone. So I describe this as my hammer test with patients. If you took a hammer and tapped your shin bone with it, or hit your shin bone fairly hard, that would hurt. There would be pain associated with that. But do you think an anti-inflammatory medication is going to help with that pain? It's not, because the bone would resemble bone banging on bone pain. There's not a direct inflammatory process involved in that situation. Osteoarthritis, by definition, is non-inflammatory joint pain. So if anti-inflammatory medications help with your joint pain, there has to be a secondary or a primary inflammatory process around the joint associated with the pain. Now, you've probably already tested this inflammatory hypothesis. NSAIDs, non-steroidal anti-inflammatory drugs. These medications do one thing. They reduce and fight inflammation. So if you've taken an anti-inflammatory, naproxen, ibuprofen, Celebrex, or any of those classes of anti-inflammatory medications, and if you've gotten any relief from those at all, it confirms there's an inflammatory process around that joint. So instead of focusing on how worn out your joints are and the structural changes around the joints, we should be starting to think of what's the inflammatory process around the joint that could be causing the pain. The structural breakdown of the joint can cause the pain directly. There's no question about that. But the inflammatory process around the joint can promote more rapid and premature breakdown of cartilage in the joint. So there's a bit of a negative feedback loop there. Another common situation we see with people with arthritic pain is quite often they'll say they have good days and bad days. Oh, it's a bad day. I woke up this morning and it was bad, and last week I had a pretty good week. So if we look at the picture of this joint, we can see structural changes here. Osteophytes are little spurs that grow to the bone. We see the cartilage starting to thin and get brittle and break down, so the bone starts to get closer to the bone. We get joint space narrowing. Once the joint has structurally broken down or a bone spur has formed, it's not there one day and gone the next. It is there permanently. So if you have joint pain that you have really good days and then you have really bad days and you have really good days, that's likely less to be associated with structural damage to the joint and more likely associated with inflammatory processes around the joint. Inflammation is triggered by the immune system, and your immune system's responses can ebb and flow depending on what the trigger for that immune system is and how often it is present in your body. So if we have some days where the trigger is more present, the inflammation can be worse. But if we have days where that trigger is less present, that can present as better days from a joint point of view. So if your joint pains ebb and flow a little bit like that, it points more towards an inflammatory process. So does your osteoarthritis diagnosis fully explain your pain? The question's not really whether or not you have arthritis. You probably do. We all have some degree of it as we get older. It's part of natural tissue breakdown. The real question is whether that diagnosis is accurately reflecting the cause of your pain. The x-rays will show joint breakdown and damage, but x-rays don't show inflammation around the joint. That's a physiological process, and x-rays show structural changes in the joint. It's these physiological and inflammatory processes that could be contributing a big part to your pain picture. Now, I mentioned in the previous slide, the question is not whether we have arthritis or not. If we're up over 40, we probably do. The rationale there is really simple. We break down on the inside the same way as we break down on the outside. When we get wrinkles in our skin as we get into our andropause and menopausal years, that's tissue breakdown out here. Well, that same process can happen on the inside as well. So the same way we get wrinkles in our skin out here, we can start to get that same breakdown in the cartilage. So we all have some degree of osteoarthritis as we get older, or structural changes in the joints associated with what osteoarthritis would be. We break down on the inside the same way as we break down on the outside. And there's actually research to support this. A 2012 study took 710 people over 50 who showed no signs of osteoarthritis on x-rays. And again, x-rays show structural changes in the joint, not physiological changes. They took all of those patients and they gave them an MRI, which actually assesses soft tissue better than x-rays do. So cartilage and ligament and tendon and things like that. They found that 89% of those people who had the MRI showed at least one type of osteoarthritic change in the joint. Bone spurs or cartilage damage in 69%, bone spurs in 74%. So again, structural changes in the joint, and many of those people were pain-free. So the diagnostic imaging of a joint doesn't give us the full story in terms of our osteoarthritic or arthritic joint pain. So the synovium, this is a simplified picture of a joint. This could represent a knee, a knuckle, a hip, any joint where bones comes together and rubs against other bone. We have the bone right here. We have cartilage represented by this thin white line surfacing the two ends of the bone. And we have a soft tissue sac called the synovium right here. This is a connective tissue sac wrapped around the joint. It serves many different purposes. One is it helps stabilize the joint. It's like a baggie wrapped in around the joint. Two, it keeps fluid in the joint called synovial fluid. This helps keep the joint lubricated and running smoothly. It has many other jobs as well. And we're talking about inflammation in the joint. Inflammation typically affects this synovium. That's where most of the inflammatory issues are with the joint. When this tissue gets inflamed, it can produce chemicals. We're going to talk about those shortly. They're called cytokines. These can cause the inflammatory pain with the arthritis. They can also promote physiological changes and pH changes in the fluid in the joint that can promote the rapid or more premature breakdown of the joint. So these inflammatory cytokines or compounds can cause pain directly. They can also cause more premature breakdown of the joint, which can then also cause more pain. So to summarize these key points, if it was just wear and tear with osteoarthritis, the pain would be steady and more constant. We wouldn't have the ebbs and flows, the good days and the bad days. Next, the anti-inflammatory medications would offer little relief. If you take those medications and you do get some relief with them, it's pointing towards an inflammatory process around the joint. And finally, the pain pattern would be mostly symmetrical. Osteoarthritic pain tends to be more unilateral, one side or the other. We wear and tear our joints according to things like leg length discrepancies, dominant hand, dominant foot. We will sit with our legs crossed in certain positions. So quite often, osteoarthritis will be highly localized on one side of the body or the other. Inflammatory pain, immune system mediated pain, these immune system compounds go through the circulatory system and the lymphatic system. They can go to both sides of the body equally. So if they can affect the synovium on one side of the body, they can affect that same tissue on the other side of the body. And so it can move side to side. It's not always on both sides, but it can be both sides at different times. That can vary depending on how you slept, what you've been doing lately, how you've been sitting, how you've been standing, and things like that. So it can migrate and move around and it can ebb and flow. Those all point towards an inflammatory process. So it's often symmetrical or bilateral. It ebbs and flows and it responds to anti-inflammatory medications. So you can ask yourself those questions. Now, many people come to me and they've been suffering with inflammatory joint pain. They've gone to their doctors and they've been tested for inflammatory forms of arthritis and it comes back negative. But yet they're coming into me taking anti-inflammatory medications. So if they test negative for inflammation, but yet anti-inflammatories help, there's a discrepancy there. Well, the common inflammatory markers that we see tested for inflammatory forms of arthritis would be something called C-reactive protein, CRP, sedimentation rate, or rheumatoid factor. Those are only 3 markers, and there's probably dozens, if not more, markers that they haven't identified for inflammation yet. There are lots of inflammatory conditions out there that don't have positive inflammation markers. I have psoriasis. If I eat the food I'm allergic to, my psoriasis flares up. If I go off that food, it goes away. I have been tested for SED rate and CRP and these inflammatory markers, and it comes back negative. But yet the treatment that I was given initially was an anti-inflammatory steroid cream. People with asthma, they get given steroid puffers, which are anti-inflammatory, but quite often they test negative for inflammatory markers on their blood work. So a negative blood test or inflammatory marker test doesn't mean that there's no inflammation. So if we combine these normal blood tests with x-rays that show normal degenerative changes in the joints, the default tends to go to osteoarthritis, the non-inflammatory form, even though people are taking inflammatory medications and they're seeing benefit from it. So the key take-home point here is synovial inflammation can be present without those positive tests showing it. It doesn't mean you don't have an inflammatory form of arthritis. So the inflammation can come first, the damage can follow. We get an inflamed synovium here. This can alter the chemistry in the joint, and that can break down prematurely these tissues in the joint. Another way to think of this, the more common order of a progression of osteoarthritis is that wear and tear leads to cartilage breakdown that leads to inflammation around the joint. In clinic, what we see quite often is the more common order. We have an inflamed synovium right here lead to altered chemistry and pH issues in the joint, and the chemistry changes in the joint lead to the premature, more rapid breakdown and advanced breakdown of the cartilage in the joint. Many people get put in this path right here from a diagnosis and a treatment point of view, when in fact they should be in this pathway over here. So more key takeaway points. The anti-inflammatories help because there's an inflammation process there. The pain is symmetrical, it goes side to side because it's involving an immune system process. The immune system goes to both sides of the body equally. What it can do, though, is take an injury on one side of the body or structural wear and tear on one side of the body and speed that side up. So it can take a normal osteoarthritic change and make it more advanced and more progressive. And finally, there are good days and there are bad days. It can ebb and flow. Inflammation can flare up and it can settle down. Those are all hallmarks of an inflammatory process in the joint that may not be directly related to structural changes in the joint. So a little quiz you can give yourself. Do anti-inflammatories help with your joint pain? Do you have good and bad days? Is it a real pattern that you see with your joint pain? Does the pain move around? Does it show up in different places? Does it go side to side? Is it symmetrical or is it highly localized on one side of the body or the other? If it moves around side to side, it ebbs and flows, it's sort of more migratory. That, again, can point to an inflammatory process. And does your pain feel worse than your imaging or your blood work would suggest? A score of 1 or 2, then the mechanical wear and tear could be the significant part of your joint pain. 2, if you have 2 or 3 positive here, there's a good chance inflammation might be part of the process. If 4 or 5 of these are true, there's a really darn good chance that inflammation is part of your arthritic joint pain picture. Inflammation is your immune system responding against something, and the immune system always has a trigger for the inflammation. So if we can identify that trigger, sometimes we can impact that joint pain. One of the major inflammatory triggers in our bodies for joints and for any other condition can be food. But I want to give a bit of a disclaimer here. We are not saying all arthritis is food related. There are injuries, structural breakdown, trauma to the joint, surgeries to the joint. Genetics can play a factor. Hydration. There's many factors that can affect the structural breakdown of a joint. Those are all very real, and they require the proper treatment. So the question isn't whether all arthritis is food related. The question would be, is some of your arthritis food related? A good example of this could be you've had hip replacement or knee replacement, but yet you still feel some pain and discomfort or inflammation around that joint. If you've had a hip or a knee replacement and you still have inflammation in that joint, it's not likely the joint anymore. The joint has been mechanically replaced with steel, which doesn't have pain receptors. When they do the joint replacement, they don't remove the tendons and ligaments and soft tissue around the joint. That is still there. That can be inflamed because of an immune system response. So if there's inflammation there, what is triggering it? The most common aspect to chronic inflammation in the body that I see as a naturopath is food-induced inflammation, specifically food sensitivities and food intolerances. Now, the term food sensitivity, intolerance, and food allergy, they get thrown around out there in natural health circles as being synonymous with each other. They are just general food reactions. But the technical differences between these types of food reactions is what makes or breaks whether people get these things figured out and whether they feel better. Real effort has to be given to differentiating these types of food reactions in a person's diet if we're going to have success in figuring out their inflammatory problems. Food intolerances are non-inflammatory food reactions. You eat a food, it doesn't get absorbed properly, It goes to the lower bowel, it ferments, and it causes a digestive tract issue like diarrhea and cramps. That's what lactose intolerance is. You eat lactose, it doesn't get absorbed in the small bowel, it goes to the large bowel, it ferments, and the fermentation process leads to gas and fluid production. The bowel fills up with gas and fluid to the point where it can't fill up anymore. The bowel cramps and spasms, and you run into diarrhea. When we described that process, we never said the word immune system or inflammation once. It was a fermentation problem. So food intolerances, they only affect you in the GI tract. They don't cause inflammation, so they're not going to cause an inflammatory joint problem. Food allergies are immediate inflammatory food reactions. The technical term is immediate hypersensitivity. This would be the classic example of a peanut allergy or anaphylaxis. These types of allergies happen as soon as you eat the food, so there's always a direct cause and effect. And they last for 6 to 12 hours normally. They have a very short half-life. This would be anaphylaxis with a peanut in the throat, or a scallop in the stomach, or strawberries causing hives. These allergies, though, don't just affect us in the throat and the stomach and the skin. They can cause headaches and migraines. They can actually take a joint pain and make it worse. It's like pouring gasoline on a little bit of a fire. They can affect us in all kinds of other parts of the body. So even though most of us think we don't have those types of reactions, quite often we do. We're not aware of them because we think of it in terms of anaphylaxis with peanuts. We can have lower grade versions of those types of reactions. The main issue that we tend to see with joints are the food sensitivities. These are delayed inflammatory food reactions. They're called delayed hypersensitive reactions. The inflammation is mediated by compounds called antibodies and cytokines. We're going to talk more about those shortly. And it's the delayed inflammatory food reactions which tend to cause most of the problems. We're going to talk about that mechanism here shortly. What I'd encourage you all to do, in the link in the description, there's a free downloadable guide that talks about these technical differences between intolerances, allergies, and sensitivities. This work is the first thing I do with patients when I see them in clinic with any inflammatory process, including joint pain, also digestive issues, organ and gland issues, skin issues, and things like that. We have to have a good basis and understanding of these differences because those differences impact how we assess and how we treat the condition. So please go to that link and download that free guide. This guide is also a summary of the first module of the course that we'll talk about at the end of the video as well. So very briefly, we'll mention it here. Food allergies, these are again called immediate hypersensitivity reactions. They're associated with an antibody called immunoglobulin E or IgE, antibody E. Immunoglobulin is a big fancy word that means antibody. These antibodies tend to release histamine. Histamine is a compound that causes redness, swelling, itching, hives. That's why people take antihistamines for seasonal allergy issues. Allergy testing that doctors do in the office, the scratch testing, the dermal testing, it typically checks for this type of immune reaction, either through IgE antibody or through mast cell reactions. Because this antibody gets in and out of the system so quickly, quite often the testing can show false negatives for this. So there can be some issues with scratch testing in terms of allergy testing. We mentioned this as well. It's not just anaphylaxis in the back of the throat. Histamine can affect our skin with hives. It can affect stomach and digestive issues, gastritis, reflux, indigestion. Some of the medications for reflux are actually antihistamine based. Histamine can cause nausea. That's why diphenhydramine, which we take when we get nauseous, helps because it's an antihistamine. Histamine can cause sinus congestion. It can cause constipation in the colon. It can cause reactive airway. So it's not just the peanut allergy reactions. We can look elsewhere in the body for these types of reactions. And the joints can actually be impacted by this as well. Now, food sensitivities, these are called delayed hypersensitive reactions. And delayed is the critical word we're going to mention here. The antibodies for this type of reaction are called IgG, IgA, and the inflammation is actually mediated by compounds called cytokines. Standard allergy testing in the doctor's office doesn't check for these types of antibodies. These antibodies tend to be associated with autoimmune conditions. So this would be more in line with rheumatology and things like that, not a typical immunologist or allergist visit. And these types of allergies, they're known to be associated with many autoimmune diseases like celiac disease as an IgE antibody-mediated condition. Ulcerative colitis has an IgG correlation with it. Interstitial cystitis, some thyroid conditions. MS has actually been shown to be correlated with an IgG antibody, not necessarily to food, but an IgG antibody response to an allergen. Now, the key point I want to make here is the IgG and IgE antibodies up here. They're the same components that get produced when you get a vaccine. So we're going to talk about vaccines next to explain this delayed food reaction. When we get a vaccine, we get a tiny little dose of the vaccine, about 0.5 milliliter, the size of the tip of a pen right here. That gets injected into the bloodstream. Our immune system cells, white blood cells, dendritic cells, antigen-presenting cells, it's a very complex interaction. But they interact with the antigen. They call over a B cell. It's a plasma cell. and they start producing these antibodies and cytokines. These are the soldiers and the ammunition that your immune system sends out to attack and kill things. So when we get that little dose of vaccine, we get a tiny little 0.5 milliliter dose right here. We can have a million-fold antibody response to it. Those antibodies can take 2 to 4 weeks to get produced, and they can last for months to years. Think of a tetanus shot. It's good for 8 to 10 years, a flu shot a year. Let's come back to this delay response right here. When you go on a trip somewhere and you have to have a shot, you have to have the shot 2 to 4 weeks before you travel. That's because this photocopy shop that produces the antibodies takes time to produce those. So you get the vaccine today, it can take 2 to 4 weeks for you to have immunity to that vaccine. Why that's important is we can have the exact same immune response to a food. We're going to talk about that next. So let's imagine you have a food allergy, the quick type of allergy. You eat the food right here, the antibody rises really quickly, and then it breaks down really quickly like this. This is why these reactions tend to come and go very, very quickly. That would be a histamine reaction. Now, if we have this delayed reaction, the same one we talked about with the vaccine, what will happen there? You can eat a food right here. The antibody can take up to 2 to 4 weeks to reach its peak, and then it can linger for a long time and break down very slowly. That's the problem. What will happen here? Let's say you eat a food right here, and the antibodies take time to get produced. Well, those antibodies could go out and affect your joints or your skin or another part of your body, 3 days later, 5 days later, 7 days later. If you eat a food today and it affects you tomorrow or the next day or 3 days from today or 5 days from today, you're not going to figure those two things out. So what are you going to do tomorrow? You'll likely eat that food again. And when you eat that food tomorrow, the antibodies don't rise from zero. They start to build up on top of each other. Every day you eat it, the antibodies compound. They go like this. This can start to lead to a chronic, ever-present, overlapping inflammation that you'll never correlate back to the food that you ate. Whereas with the histamine issues right here, you eat the food, quite often you have the reaction right away. So there's a direct cause and effect. So we can eat a food today that can affect our joints next week. And because we don't correlate that, we eat the food over and over again. So the joints end up chronically inflamed because these antibodies linger for a long time. Now, these histamine issues can be present and we don't know about them because the delayed allergies can mask them. So let's imagine you eat a histamine food right here that causes a little bit of a joint pain problem right there. You can also eat a food last week right here that can cause the exact same joint problem right there. The delayed allergies can lead to a chronic inflammation that can mask and hide some of these more immediate types of responses. So the way we can identify these histamine issues is to get rid of the delayed allergies. The way you can think of this is if you don't feel well after supper tonight, we're not sure if it's what you ate at supper tonight, what you ate yesterday, or what you ate last week. By getting rid of these delayed allergies here, and then if you have an issue, then you can more directly correlate it to what you just ate. So this process is really critical in terms of sorting through which food reactions are quick and which food reactions are delayed and what parts of the body they affect. So how can these foods actually affect the joints? One common mechanism or hypothesis is a concept called molecular mimicry right here. And it's not really theoretical. We're going to use celiac disease as an example to explain this. With celiac disease, someone eats gluten or gliadin, a wheat protein. It gets in through a concept called leaky gut. We talk about that in an IBS video. When this protein gets into the bloodstream, it interacts with our white blood cells, and we produce these antibodies and cytokines right here. Those are little soldiers that go out in the body, and they look to attack anything that has this protein structure. Well, people with celiac disease can have a protein in the bowel that looks like this. You eat this food, you produce an antibody response to it, and those antibodies cross-react with a tissue protein that looks like it. It's a really simple concept. Molecular mimicry means you eat a molecule you have a reaction to, and you have a tissue that mimics it, and you get a cross-reaction. So if this can happen with a wheat protein and a cross-reaction with the protein in the bowel, why couldn't it happen if that person had those proteins on the surface of the synovium, or in the skin with eczema and psoriasis, or on the thyroid gland with thyroid issues? We can eat this food, we produce an antibody response to it, and they cross-react with that synovium. What happens here, though, this antibody response can be delayed. So you eat the food today, you may not have joint pain for a day, 3 days, 5 days, 6 days from that food. That's where the confusion happens. So molecular mimicry in mainstream medicine, that's not a hypothetical concept. This concept's been known with rheumatic fever for over 70 years. Someone gets a strep infection, they produce an antibody to the strep infectious agent. That antibody can cross-react with specific tissue proteins in the heart and other parts of the body. That can lead to inflammatory heart damage. We already talked about the gluten gliadin issue with celiac disease. There's lots more research on this. And what I encourage you to do, I have 2 books. The links will be in the description. One is a much more detailed version of what this video is about. It's on inflammation and arthritis, what we're talking about in this video. There's another book on autoimmune disease and diet, and this digs more into the molecular mimicry concepts and research supporting that. So it may sound like a new concept to you, but there's a ton of research supporting this concept. The links will be in the description for those books. Here's a study from 1991. Rheumatic arthritis patients, rheumatoid arthritis, an autoimmune condition, they were shown to have elevated levels of bovine serum albumin, a protein found in cow's milk. And what they did is they found that that protein compound in the cow's milk looks structurally similar to human type 1 collagen found in joint tissue. So if someone was allergic to bovine serum albumin, their hypothesis here is those food antibodies could cross-react with that collagen in that tissue. Another study in 2006 on rheumatoid arthritis patients. They studied these patients. They were found to have elevated levels of milk, wheat, egg, and certain fish antibodies in the gut fluid, which would indicate a gut immunological reaction in the rheumatoid arthritis patients. So it showed a correlation on the axis from the gut to the joints. So again, this isn't just a theoretical concept. More mainstream support for this molecular mimicry mechanism with joint pain. In the diagram before, we showed ingestion of the protein, the interaction with the immune system, and the production of these antibodies and cytokines right here. The antibodies target the protein specifically, the cytokines go and cause the inflammation. Well, many of the new drugs that we see marketed today, the biological drugs, some examples are listed there, for various autoimmune diseases, skin disorders, inflammatory bowel disease, but also inflammatory joint issues like rheumatoid arthritis. These biological medicines work by impacting these cytokines. They block the action of the cytokine. So by blocking that inflammatory mediator in the joint, we see improvements in the joint. So that's actually tying the joint pain and inflammation back to this immunological response way back here. So I'm not suggesting these drugs are necessarily bad. What the drugs don't do, though, is they don't identify the allergen that led to the production of the cytokines. If we can identify and remove that trigger for the inflammatory response, we can stop the production of the antibody and the cytokines, and therefore we won't have to block it. Now, reasons why we don't connect the food to the flare-up in the joints. One is this delayed inflammatory response. We talked about this. The antibody and cytokine in response to the trigger can take days to build and eventually get to the joint and cause the problem. These antibodies for a tetanus shot last 10 years, for a flu shot a year. Well, the antibodies for food can have a half-life of 1 to 3 months. So we can be looking at 3 to 9 months to get something substantially out of the system. The immune response can last for a long, long time. The antibodies can compound. We eat a food today, it bothers us next week. We don't figure that out, so we eat the food over and over again. Every time we do that, the antibody level compounds and goes up. So it tends to overlap. So the inflammation may ebb and flow, but it never really goes away. The rolling flare, whatever the trigger is for the immune system, it may ebb and flow in terms of exposure in your body. It might be a dietary component or something like that. So if there's a dietary component and we eat that food in fits and starts, we may eat a lot of it one week and not so much the next week. Well, the week we eat a lot of it, we may have a bad week the next week. And then the week we don't eat a lot of it, the following week may be better. So it's going to sort of roll and ebb and flow like that. And as we talked about, the standard allergy testing isn't for these delayed type of antibodies. So it can tell us we're not allergic to a food that we may have an immune response to. We may not have a positive scratch test to dairy or egg or wheat, but it doesn't mean we're not having an IgG or an IgA antibody response to that item. So when we put all these together, it's very easy to see why these issues are so hard to correlate back to immunological triggers and especially food triggers for inflammation in our diet. So why it flares and settles down? Well, we already talked about the delayed and overlapping compounding and rolling flare response. Some other aspects though. Hormonal and anti-inflammatory effects. Our cortisol level, which is our body's anti-inflammatory, major anti-inflammatory hormone, this hormone follows what's called a circadian rhythm. As we go to bed, our cortisol levels rise. We wake up in the morning and the stresses of our day, of which inflammation is one, drain the cortisol level. So this can cause, we may feel good in the morning and we start to get sore later in the afternoon because our hormone's ability to fight the inflammation lessens as we go through the day. But other hormones as well, estrogen, progesterone, testosterone, they are not just sex hormones. These hormones are also anti-inflammatory hormones. So as these hormones ebb and flow, a woman may notice more joint pain before her period and less joint pain once her period starts in the first half of her cycle. But more importantly, these hormones fall as we get older. These hormones support epithelial tissue, they support cartilage, they fight inflammation, but they're also sex hormones. But most of us only think of them as sex hormones. Well, at least half of their job is anti-inflammatory function. So as we get older, as we go through andropause and perimenopause and menopause, these hormones fall. Well, the inflammation that they were suppressing can start to surface. I have a separate video just on this. It's called Menopause Isn't the Cause, It's Inflammation. This relates to men as well. Andropause and menopause are both drops in steroid hormone. It's not just from a sex hormone point of view, it's from an anti-inflammatory hormone point of view. So this menopausal video will actually apply to both men and women if your joint pain has been aggravated or worsened since you've gone into your 40s and 50s. I'd encourage you to go watch that video. Our inflammatory reactions to foods are immunological reactions. It involves a white blood cell, which we see right here. These cells have receptors on them. They're like little locks, and we have to put a key into the lock to trigger the inflammation. These receptors are like little arms with feelers on the end. They're designed to reach out into the tissues and bounce into things and touch things, and they can feel them and determine if it's allowed or not in your body by how they feel. Well, the shape and the structure of these little receptors will determine what binds to it. You can see here, square to square, triangular to triangular. The coding of the shape and structure of those receptors is determined by your genes and DNA. So what we're allergic to, what these immune system cells respond to allergically in our diets and elsewhere, it's coded by our genes and DNA. Our genes and DNA determine the shape and structure of those receptors. Think of them as the lock, and we have to put a key into the lock. Well, only one key will fit into one lock. So each of these receptors can be different. Also, these receptors in different people are going to bind and react allergically to different things. What we're allergic to in our diet and in our environment is determined and coded by our genes and DNA. It's not determined by prepackaged anti-inflammatory or generic diets off the internet or by your favorite internet guru. This is why sometimes generic anti-inflammatory diets quite often don't help with these types of problems. Your ideal anti-inflammatory diet is unique to you and you alone. So that's the key that we have to figure out from a joint pain point of view. If you've tried an anti-inflammatory diet or a generic elimination diet and it didn't work, it doesn't mean diet isn't part of your picture. It just means you didn't do the right diet. So there's another video I encourage you to watch. It's called The Trouble with All Anti-Inflammatory Diets. It's your genes and DNA. It shows in detail how the immune system interacts with these food proteins, these allergenic proteins, how it can lead to tissue responses that affect joints and skin and other parts of the body. But it also clearly shows how our genes and DNA determine what we're reactive to. And also it shows many different examples, test examples, food sensitivity test panels that show people can have inflammatory responses to foods that are generically thought of as being anti-inflammatory and vice versa. I'd really encourage you to go watch this. So to these generic approaches, some of the common pitfalls we see with it, your joint issues, your inflammatory issues are unique to you and you alone. So we can have 10 people with inflammatory joint issues. They can have 10 different sets of foods that are affecting it. If they all go by the exact same program, some may get partial response. None of them are likely to have full, complete responses. Quite often on these generic anti-inflammatory diets, we're told to eat healthy foods. Well, our immune system can just as easily react to what's perceived as being a healthy food as to an unhealthy food. So generic healthy isn't always healthy. The trigger's not always an obvious one. We tend to think, well, sugar or fat or processed foods. With allergies, the triggering mechanism for most food responses is the protein in the food, not a fat and a sugar molecule. Fats and sugars can cause lots of other problems. But from a white blood cell receptor, which is protein-based, they interact with other proteins. So these inflammatory components in foods aren't quite often what we think they are. And the delayed food reaction, we eat a food a day and we can have a reaction anytime in the next 7 to 10 days. That makes it almost impossible for us to figure these out. This is also why food journaling isn't very effective for the delayed response. If you write down everything you eat and today you have a joint flare-up, how do you know what it was you ate in the last 2 weeks that caused that flare-up? You'll also find examples where, okay, I had a flare-up tonight for supper. You look at what you ate at supper and you're going to say, well, I ate that last week and I didn't have a flare. It's because you're trying to correlate your symptom to the food you just ate. Well, this delayed response can negate that type of concept. So these are some of the more common pitfalls we see with generic diet approaches from a joint pain point of view. So these generic elimination diets aren't based off your genetically programmed inflammatory food profile. They are a guessed list. They are based off population averages. Quite often, we don't have just one food issue. We have several food issues. Well, if you take foods out one at a time, it's like you're trying to unlock a wall safe with only one number of a 3-number combination. You get one number right, it doesn't open up the safe, so you mess that number up and you get another number right, and so on and so on. We have to get the right combination of foods out at the same time in order to see the responses. The elimination diets quite often aren't done long enough. With these delayed antibodies we talked about, it can be 2 to 4 weeks on the diet before the antibodies even start to fall. So with some foods, we can be looking at 8 to 12 weeks before we're going to be seeing really substantial improvements if we get the food right. The elimination diets often aren't done strictly enough. People say, okay, well, I'll cut that food back. I won't eat cheese and I won't eat yogurt, but I still just a little bit of cream in my coffee once a day won't hurt me. Well, that's like saying to a kid with a peanut allergy, you don't need a lot of peanuts, but just have one peanut and you'll be fine. Or to a celiac patient, don't have a whole loaf of bread every day, but one slice is going to be okay. Our immune systems, it's more the frequency of the food that's eaten versus the volume of it. So the concept of everything in moderation from an allergy point of view doesn't really work. And the food challenges quite often aren't done properly. We take the food though we feel better and we think, okay, the diet's done. So we put all the foods back in at the same time. Well, if you feel sick 2 weeks later, you have no idea which of those foods you took out and put back in caused the problem. So doing the elimination diet the right way is critical, but also putting them back in the right way is equally as important. So the investigation we have to do from a food point of view, it has to be done systematically. It's not just do another elimination diet. People say, I did an elimination diet, it didn't work. And what I say to them is, you did an elimination diet, you didn't do your elimination diet. That's what we have to figure out. So we don't want to do just a more disciplined version of the diet program you've already tried and that didn't work. So it has to be a technically different method. We have to identify the delayed antibody reactions, and then we have to identify the histamine reactions if there are any. The delayed ones are the critical ones to figure out. When we do the eliminations, we have to take into account the differences in timing from the response. Some foods, they bother us 3 days later, some 5 days later, some a week later. The histamine reactions happen within 6 to 12 hours usually. So when we do eliminations, but also the challenges, we have to have an understanding of those different concepts in order to do the process correctly. And finally, we have to account for the unique and individual nature of the inflammatory immune response in each of us. Our immune systems, again, don't care what the internet says is healthy for us, what our favorite health guru or what YouTube says is healthy for us. It's different for all of us. And that's what we have to figure out. So the investigation can be hard. No one likes giving up their favorite foods, and it's usually going to be your favorite foods that cause the problem. What we don't eat can cause our problems, and we don't eat what we don't like to eat. So none of us want it to be the case, but it doesn't mean it's not causing a problem. So the rewards for going through this hard work likely aren't going to be just joint improvements. When you have your immune system affecting or causing inflammation around your joint, very seldom is it only affecting your joints. Quite often, we're going to see impacts in other parts of the body when we do this investigation the right way. Quite often, we see digestive issues, IBS issues, chronic reflux, indigestion or heartburn, constipation or diarrhea, bowel irregularity. From a dietary point of view, those are quite often inflammatory problems. If something can trigger inflammation in one part of your body, it's natural to think it could trigger inflammation in other parts of the body as well. The digestive tract issue, if we have a food issue, logic and common sense says it's likely going to impact us there before it can impact us systemically, like in the joints. So we can see, along with the joint problems, we can see muscle problems. PMR, for example, from an autoimmune point of view, there's some research supporting this in the autoimmune book I mentioned earlier. But also more chronic issues like things like fibromyalgia and just muscle pain and muscle soreness. Skin issues with eczema and psoriasis. I've talked in many videos. I have psoriasis. The trigger food for my psoriasis is rice. Now, most people perceive rice as being benign and very hypoallergenic, but for me, it flares me up. For another person, it might be a different food. I've actually seen psoriasis triggered by carrot before. Who would think that carrot could cause an inflammatory problem? Well, that person's immune system recognized carrot as being bad. I'm not saying arthritis is caused by carrot. I'm saying that was an example. Your food issue may be completely different. Subjective symptoms with inflammatory responses. These cytokines can cause things like brain fog and fatigue and anxiety and sleep issues. The next video that's going to be coming out is actually on brain fog and inflammation. So if you're curious about that, subscribe below and you'll get notification of that video. So when we go through the process of identifying the inflammatory trigger that may be impacting our joints, the benefits will be seen in other parts of the body as well. So the reward for going through the hard work can be more than just your joints. So does this apply to you? You have good days and bad days with your joint pains, and you have a week where everything's fine, and then another week you're inflamed and sore. Does the joint pain move around and migrate and go side to side? Is it more bilateral or is it more highly localized? If you've taken a specific anti-inflammatory, not acetaminophen, but an NSAID medication, and if you got relief from it, that points to an inflammatory process. You have other possible inflammatory issues, digestive issues, fatigue, along with the joint pain, hormonal imbalances, sleep issues, or energy and fatigue issues. Did you get tested for inflammation and the test came back normal, but you still respond to anti-inflammatory medications? And have you tried other generic anti-inflammatory and generic diet recommendations and didn't see much improvement? With these questions, if they tend to resonate with you, it can be suggestive that there may be an inflammatory food component to your joint pain. So it's definitely worth considering. So where do we start? I already mentioned before this downloadable e-guide, this ebook on intolerances, allergies, and sensitivities. That's the first work I do with every patient in clinic, and I've done it for 26 years. We have to go through this investigation and determination of which food reactions the person may be having. And we have to make sure the patients understand these technical differences, because when they go to assess whether a diet plan is working or not working, that's where these terms really come into play. So there'll be a link in the description. You can also go to that QR code. It'll take you to the download site. So if you think inflammation may be part of your puzzle from a joint point of view or from any other inflammatory point of view, go to that site. So specifically for inflammation and arthritis, I would go to that book. The QR code is right here. There's a link in the description. This is a much more in-depth explanation on all the topics that we covered in this video. Plus, there's citations and research there to support some of these claims and ideas that we've talked about. So if this is of interest to you, I'd encourage you to go there as well. Now, the best way to work through this whole inflammatory process is with a practitioner who is well-versed in these concepts, a functional medicine practitioner who's familiar with diet and inflammation and these types of concepts. But those practitioners aren't always accessible for everybody. So I have put together an online program, a course, that provides all the technical details and algorithms and processes that we use with patients in clinic so they can try and sort through this inflammatory food process on their own. The first module of the course is actually summarized in that ebook that we talked about earlier. There's 10 other modules. It's a video course. The first 4 modules give you all the critical background information from an allergy process point of view. The next modules talk about the algorithms and the processes we use to remove the foods, to challenge the foods. It takes into account the differences in timing for eliminations and challenges. And it talks about food sensitivity testing and options to identify your foods to put into the elimination diet. So if you don't have easy access to a functional medicine practitioner to work through this with, that's an option for you as well. So to summarize, do you have arthritis? You probably do, especially if you're over 40 or 50 years old. But is your arthritis pain solely because of joint breakdown, or could the joint breakdown be aggravated and influenced by an inflammatory process? We gave you a few assessment tools here to sort of sort through that question with yourself. If you think there might be an inflammatory process going on, the rewards may be well beyond just joint pain. So I encourage you to all give it a try. Thanks, and we'll see you in the next video.